Hello, Brian Alston. Can you hear me? Sound check. Excellent. Thank you very much. Mm. hello, everybody who is connected remotely. If you can just be patient, we will be starting the meeting in approximately 5 minutes. We are awaiting a quorum.
Okay. I'd like to call the meeting of the board to order. Will the secretary please call the roll?
Director Bott is absent. Director Curry?
Present.
Vice Chair Deere is absent. Director Garza?
Present.
Director Harrington?
Present.
Director Ryder is absent. Director Robinson?
Present.
Director Sorrell is absent. Director Webster Cross? Present. And Chair Taylor.
Present.
You have a quorum.
Thank you. The next regular meeting of the board will be held on Friday, June 28th at 9 a.m. The first item on today's agenda is employee recognition, which will be reviewed by Dr. Eric McIdas. Dr. McIdas.
Thank you, Chair Taylor. Good morning, directors.
Morning. Morning.
Morning.
Morning.
All right, we'll wait for the slide. Okay, as always, we'll start with our new team members and bid them welcome. Starting with Emma Misra, Executive Director of Quality Assurance and Care Management. Joe Kathy Roberts, Chief of Police and Public Safety. Manuela Salinas, Clinical Laboratory Quality Manager. Shamil Johnson, Grant Administration Manager, Public Health. Jennifer Duran, Manager of Community-Based Trauma Programming. Nikelia Franklin, Manager of Complex Care Coordination, Managed Care. Rashid Mohammed, Manager of Emergency Operations, Public Health. Donna Miller, Manager of Population Health and Performance Improvement, County Care. Idessa Butler, Senior Project Manager, Strategic Planning and Implementation. Samantha Shufflin, Program Manager, County Care Operations. Omar Sharif, Business Manager 3, Plant Operations. Manasi Bora, Physical Therapy Associate Manager, and Antonio Wheeler, Supervisor of Trauma, Intervention, and Peer Programming. And we also want to congratulate and recognize our team members who earned promotions over the last month. Marlon Garcia, Medical Division Chair, Postgraduate Education. Shane Pino, Senior Manager of Delegation and Vendor Oversight, County Care. Marla Blanton, Manager of Public Health Workforce Strategy. And Angela Whitaker, Nurse Coordinator to CERMAC. And we'll move to recognitions. And as I go through these, if you're in the room, please stand so we can recognize you. We'll start by sharing a great announcement. Our Leapfrog Hospital Safety Grade came back for Stroger, and we managed to maintain a B this time around. And as I'm sure everyone is aware, Leapfrog Hospital Safety Grade is the only hospital rating focused exclusively on safety and ranks nearly 3,000 hospitals. We had some really great events this month as well. We did a neurocritical care ICU ribbon cutting at Stroger that was on May 28th. Cook County Health leaders were joined by President Preckwinkle to celebrate the opening of the new neurocritical ICU at Stroger. The unit is staffed by board-certified neurocritical care physicians and specialized APNs and includes state-of-the-art equipment to provide advanced care to patients needing complex neurological care. We also celebrated our Nursing Excellence Award ceremony. Congratulations to everyone who was nominated. Our award recipients for 2024 are Arhaney Villasenor, Nurse of the Year, Aisha Meggie, Rising Star, Sherry Spencer, Leadership, Jeelan McCrae, Correctional Health, Rosa Rodriguez, Community Care, Jaretha McColmy, Clinical Nursing, Rodalyn Bedford, Education and Mentorship, Christina Guerrero, Excellence in Public Healthcare, Linda Liu, Volunteerism, Justin Robinson, Patient Care Support, and Thomas Bliss, Partners in Nursing. We also want to recognize Dr. Fegan, who had 2 recognitions this month. On May 16th, Dr. Fegan was honored with the Lifetime Achievement Award in Social Justice and Healthcare Equity and Reform by the I Am Able Foundation. At the annual Chicago Health, Medical, and Law Careers Citywide Student Conference, the theme for the year was On the Shoulders of Giants. And she was also recognized by Becker's Hospital Review on the list of Black healthcare leaders to know. Congratulations, Dr. Fegan. We also want to recognize Justin Miss, who we're calling our Wrigley Field hero. On April 25th, Justin was walking home from a Cubs game when he noticed a family in distress and who had an unresponsive baby. He started performing compressions until paramedics arrived. The baby ended up surviving and is doing well. And he was recognized by Lurie's Children's Hospital as well as the Chicago Fire Department for the heroic actions at a press conference last week, and he got to chat with the family as well to check in with them. Congratulations, Justin.
Well done, thank you.
We also want to recognize our Daisy Award winner for this month, Muna Yusuf. She is a nurse on 7 East at Schroeder. She's being recognized with the Daisy Award, which is a program to celebrate and recognize nurses by collecting nominations from patients, families, and coworkers. I don't think Muna's with us. Okay. We also had 2 mural paint parties in the last month, Austin and Cottage Grove Health Centers. We had staff, patients, and community members contributing their artistic talents to the painting panels that will be installed as part of the new murals at the health centers. We have 4 plans across some sites this summer, and we want to also thank the Cook County Health Foundation for their support. We also received awards for the 22-23 Choice Campaign. There's a plan for that for County Care. They won several Astor Awards, honoring excellence in healthcare advertising, including the Judge's Choice Award for Total Advertising Campaign that required a perfect score from the judging panel. They also got gold for multilingual advertising and bronze for TV video advertising. In all, this campaign has won 7 industry awards. Congratulations.
Well done.
And I think that concludes my initial report.
Thank you. Thank you. Well done. Congratulations to all and welcome to our new hires. The next item is public testimony. As a reminder, written testimony will not be read into the record, but will be included in the official record of this meeting and posted to the website. Madam Secretary, do we have any speakers who registered to provide in-person or virtual oral testimony or submitted written testimony?
We do have 2 registered speakers. The first speaker is Tina Montanez. And just a reminder to speakers, you have 3 minutes, and around 2 minutes, 30 seconds, I'll give you a reminder that time is closing.
Hello, good morning.
Good morning.
My name is Tina Montanez, and I've been a nurse at Cook County Hospital since 2004. I am here today on behalf of our nurses, 600 nurses that signed a petition, and with the National Nurses Organizing Committee. There are too many unsolved and ongoing issues that we are facing. NNOC nurses have lost confidence in the competency and intentions of the Human Resources Department within Cook County Health. As I mentioned, there are too many unsolved and ongoing issues that we are facing, such as the nursing staff throughout the system continues to be replaced with outside agency. Also, management failed to protect and retaliated against staff nurses who reported sexual harassment by an agency staff, leaving offender on the schedule for over a month. Also, management fails to timely process tuition reimbursement requests. Management has not agreed to union proposals that would alleviate the staffing crisis, including extra shift bonuses and the reclassification of nurses in public health and other departments. Management is preventing qualified nurses from working overtime in critically understaffed departments, putting patients in harm's way. Management is inserting themselves in nursing practice issues, even when union nurses and nurse directors agree on matters of patient care. We demand that for every agency nurse employed for more than 30 days, that Cook County post union positions immediately per the collective bargaining agreement. We demand that the directors of human resources be held accountable and that they be removed from their positions. We will not sit idly by those with authority continue to abuse their power and try to bust our union. We demand accountability and expect better from Cook County in shared commitment to uphold our mission and to provide quality health care to our patients and the communities that we represent and love.
Excuse me.
Thank you.
Oh, that's all right. 30 seconds remaining.
Thank you.
Thank you.
Thank you. The next speaker is remotely connected, and that is Brenda Langford. Brenda, can you hear me?
Yes, you hear me?
We can see you and we can hear you.
Thank you. Hello and good morning. I am Brenda Langford. I'm the Region 13 board member for NNOC Nurses, Chief Nurse Rep, and a Cook County nurse for 26 years. There are many ongoing concerns that we have about the HR practices in hiring and in the retention of nurses working for Cook County Health. There are nurses that obtain advanced degrees and have received tuition reimbursement that are still unable to find positions in these classifications. Inefficiencies in the HR to post and interview these nurses for vacancy is causing many of those nurses to consider leaving Cook County to find employment elsewhere. There are nurses that are still waiting for tuition reimbursement 9 months to a year after finishing their classes, but our nurses are required to submit their receipts in a time frame in order to receive their reimbursements. HR has been obstructing contractual rights to request reclassification of pay for public health nurses. Even the leadership and public health department has recognized hiring difficulties related to the uncompetitive pay and have supported the reclassification of pay due to this critical staffing issue to meet the state metrics and fulfill Cook County and to fulfill programs, that Cook County is currently increasing advertising to promote. There are nurses that work in public health that have waited 8 months to receive their travel reimbursements for their valuable work in the field servicing our communities. HR should allow clinically trained managers and nursing leadership to decide on important nursing matters instead of intervening and obstructing agreements between nurses and their nursing management. HR has also shown the inability to develop processes to allow committed staff and skilled nurses the ability to sign up for overtime opportunities and provide chargeback to the correct budgets. Instead, HR is denying nurses overtime opportunities, leaving our patient care units short-staffed. And HR has been untimely in responding to our grievances, which is causing a backlog and requiring advancements to the third step, and for the Bureau of Health Resources to step in to settle, and which is causing a delay in justices to our nurses. Shortages in staffing for our units further impact recruitment of new nurses and being able to retain the nurses we have. With no new nurses, no new staff nurses, how does Cook County implement any new policies or start any innovative programming? This does not align with the Magna status or the pathways to excellence. Cook County is already showing signs of inability to hire nurses to fill these vacant positions. And Cook County has previously agreed to offer recruitment bonuses to incentivize new applicants, but the HR department has now sunset that agreement. NNOC nurses are asking our commissioners and our board members to take a closer look at the hiring practices and inefficiencies in HR so that we can fill the vacant positions that Cook County committed to during our last bargaining contract to relieve the staffing crisis and ensure that we have the necessary staffing to fulfill our commitments to serve the patient population of Cook County. Thank you.
Thank
And that concludes, the public testimony.
Thank you. Next on the agenda are the board and committee reports. The minutes of the April 26th board meeting are being presented for your approval. Are there any corrections or revisions, directors, that need to be made to the minutes? Hearing none, I'd like to entertain a motion to approve item 4A, the board meeting minutes of April 26, 2024.
So moved. Second.
The motion has been made and seconded. Is there any discussion on the motion? Hearing none, all in favor? Aye. All opposed? Thank you. The ayes have it, the motion carries. Next, Director Garza will review the Human Resources Committee meeting minutes.
Thank you, Chairman. Good morning. The Human Resources Committee met on Monday, May 20th at 12 p.m. The next regular meeting of the Human Resources Committee will be held on Thursday, August 15th at noon. We're not planning to have staff re-review the report from the meeting. Any additional questions are raised regarding the presentation and metrics contained within the minutes. Staff are here to present and they're ready to address such questions. We did receive a report from the Chief Human Resources Officer, which is included within the minutes and included information on the following subjects. Strategy FY 2024, specific to this year's action plan, HR operations, optimization, and digitization, CCH employee exit survey findings, the FY 24 metrics, FY 24 CCH HR activity report, and the HR optimization, HR nurse recruitment. The committee did not go into closed session, so if there are no further questions, the minutes are being presented for consideration at this time, Mr. Chair.
Thank you. Any questions? Okay, perfect. Right. I'd like to entertain a motion to approve item 4B, the May 28th minutes of the Human Resources Committee meeting.
I'll make the motion.
Second.
Thank you. The motion has been made and seconded. Is there any discussion on the motion? Perfect. All in favor?
Aye.
All opposed? Thank you. The ayes have it. The motion carries. Next, I'd like to entertain a motion to allow Director Bott to participate in this meeting remotely.
I'll make the motion.
Second.
Motion is made and seconded. Do we have any discussion? Thank you. All in favor?
Aye.
All opposed? Thank you. Motion carries. Thank you. Next now, Director Bott will now review the Quality and Patient Safety Committee meeting minutes.
Thank you so much, Mr. Chair. Good morning, everybody.
Good morning.
The Quality and Patient Safety Committee met on Monday, the 20th of May at 10:30 a.m. Committee approved the following action items, which are included in the minutes. Approved 1, Stroger Hospital Department Chair initial appointment. Approved Stroger and Provident Hospital medical staff reappointments, appointments, and changes. The committee received the following reports, which are included in the minutes for your review. Updates from the following operational excellence work groups: patient experience at Stroger Hospital, patient experience at Provident Hospital, patient experience at ACHN, and Throughput Provident Hospital. OpEx dashboard, as well as received regulatory and accreditation update. The next meeting of the committee is slated to be June 7th at 11:30 a.m. Committee received informational reports in closed session. Those are not expected to be re-reviewed. If there are no other questions on the minutes, they're being presented for the board's consideration at this time.
Do we have any questions? Thank you. Then I'd like to entertain a motion to approve item 4C, the May 20th meeting minutes of the Quality and Patient Safety Committee meeting, which include the approval of 1, Stroger Hospital Department Chair initial appointment, and approval of the Stroger and Provident Hospital medical staff appointments, reappointments, and changes. Do I have a motion?
So moved.
Second.
Thank you. The motion has been made and seconded. Is there any discussion of the motion? Perfect. All in favor?
Aye.
All opposed? Thank you. The ayes have it. The motion carries. Next, we're going to have the finance committee. Are you prepared?
Oh, yeah.
Okay. Of course you are.
And I apologize for being late, if I could be added to the roll.
We so noted. Next, Director Ryder will review the finance committee meeting minutes. Thank you.
The Finance Committee met on Monday, May 20th at 1 p.m. The next scheduled meeting of the committee was originally scheduled for Friday, June 7th, but we are looking to reschedule. The committee considered the following action items, which are included in the minutes. We approved a real estate item, request to enter into a lease for use of a space in a building located at 2101 to 2171 West 22nd Street, Cermak Road, Broadview, Illinois. The space will be utilized by the Cook County Department of Public Health for a vaccine distribution center for the purpose of providing safe storage of necessary supplies of vaccines that can be easily distributed throughout the county as needs arise. We conditionally approved 39 contracts and procurement items, number 4, 5, 6, 17, 18, 22, 27, 28, 30, and 38 are pending review by contract compliance. On the screen, you'll see the contractual requests from the Finance Committee whose fiscal impacts are greater than $1 million, which are highlighted for your information. We received and filed grant award related items. We also received and filed transfer of fund items. The committee received the following reports, which are also included in the minutes. The fiscal 2024 first quarter report of contracts executed under the authority of the interim CEO, and report of the March 2024 financials. If there are no questions from the directors, the minutes are being presented for the board's approval at this time, Mr. Chairman.
Thank you. Any questions? If not, I'd like to entertain a motion to approve item 4D, the May 20th Finance Committee meeting minutes, which contain the following action items. Approval of a proposed real estate item for use of space in a building located at 2101 to 2171 West 22nd Street in Broadview, Illinois. Approval of the contracts procurement items, and receiving and filing of grant award related items and transfer of funds. Do I have a motion?
So moved.
Second. Thank you. The motion has been made and seconded. Is there any discussion on the motion? Hearing none. All in favor?
Aye.
All opposed? Thank you. The ayes have it. The motion carries. We do not have any contracts being presented directly to the board for its consideration, so we can move on to the next item. Next item is a report from the interim CEO. Thank you.
All right, good morning once again, and thank you. We are going to try to kind of frame this discussion around a strategic plan update, but then we'll also give a bit of a nursing update and an update on value-based care.
Thank you.
Morning.
I'm Andrea Gibson. I'm Chief Strategy Officer, and I was last before you in February to go over kind of our focus areas for this coming year. If you recall, we reduced the number of strategies to work on from around 250 to 27. And you had asked at the time for an update later in the year, and so that's what we're providing. And it was a great exercise, actually, to see that most of the things that we had wanted to do this year, that we've made some progress. So we're ready to go. Yeah, the next slide. And I think we also shared what our new process would be to monitor the progress of initiatives. We're still getting that in place, but we've made a lot of progress since February. Next slide. So as you recall, in the strategic plan, we have 7 pillars. The first pillar is our quality pillar, and Raji Thomas is leading the implementation of this pillar. And you can see that the big item here is continued improvement in quality metrics. And so that encompasses a lot. And certainly the leapfrog score of a B is something that has occurred, but we also received a lot of either recognition or reaccreditation or accreditation for various services that indicate quality of healthcare that we provide. We've also improved our sepsis compliance from the last 12 months significantly. As you can see, it went from 17% in February of 2023 to 81% March of 24. Provident has done a great job of decreasing the left without being seen in the emergency room. We've expanded some services both at CERMAC and at Provident to improve the quality of care at both of those locations. Nursing, and I'm sure you'll hear more about this momentarily, introduced a shared governance model during Nurses Week relative to the Magnet or Pathways to Excellence approach. Also, there have been some unit-level daily huddles and huddle boards established so that there's standard data that units are reviewing routinely. And of course, you're aware from last month's board meeting, we implemented robotic surgery. Next slide. Also, under the quality pillar, we have two other strategies. One is for county care to maintain top quality outcomes for county care members. And the second one is around grants and research infrastructure. For the county care quality, some of the strategies have started to be implemented around primary care provider engagement, maternal child health, behavioral health, telehealth in particular, and then executing more value-based care agreements. And we'll talk more about that in a later presentation. Under grants, we've been working to build the team to develop the research infrastructure for the scale that we would like to accomplish here. We signed a contract with Hectone that you're also aware of to transition grants. We've launched a toolkit in the IRB to strengthen our compliance, and we're testing new processes to support clinical trials. Next slide. So the next pillar is the equity pillar, and that's led by Shannon Andrews, Chief Equity and Inclusion Officer. And the first strategy under equity is increasing access and improving outcomes in targeted areas. And county care has looked at some services that are needed amongst their member population and has expanded access for eating disorders and root canal services. CERMAC was awarded an opioid settlement fund to support treatment for CERMAC patients. We also are pleased to report that we received a $5 million grant for the Healthy Start program for the next 5 years through HRSA for maternal health. There's a lot of activity this year so far to report on relative to mental health. CCDPH had a campaign, Here to Hear You. The Office of Behavioral Health also had the summit and launched the open call for the $44 million in grants. We've had a fair number of outreach events, health fairs, specifically related to cervical cancer, colon cancer, but also women's health fairs and men's health fairs to try to bring more people into care for those services. We did receive a performance bonus based on outcomes of work that we've been doing with the transformation project, Wellness West. We've established a new dedicated CareLink program webpage. FoodSmart referrals, FoodSmart is the vendor that County Care has to provide medically tailored meals and access to food for those that are food insecure. And we've linked that within our Cerner system, within the EMR, so that County Care members who are also patients of Cook County Health can easily get referred to FoodSmart. Next slide.
I have a question.
Sure.
The $44 million in grants at open call, what's the status of that?
The status of that is the review is complete, and I believe June 10th is the unveiling of the recipients. I think there were over 300 applicants for the $44 million, and so in a few weeks, we'll have finalized the process, the review process there, and award.
It'll be here at noon on June 10th.
Okay.
An open announcement.
All right, next slide, please. Two more strategies under the equity pillar. One is ensuring access to healthcare information, specifically focusing on language access. So we've rolled out new equipment for language services. We've hired and trained additional interpreters. We've also done system-wide training on utilizing the interpreter services and have an improved process for submitting requests for those services. The last strategy under this pillar is streamlining the procurement process and improving the MBE-WB participation. We've completed process enhancements to our contract oversight committee, rolled out training and forms to support that hopefully will be more user-friendly than the ones previously. We've done education and training, prepared education and training materials both for user departments and supply chain management. We're using our internal process to flag MWBE goals and identify more opportunities for target market earlier in the process. So we hope that'll bear out in the numbers as we go forward. We've also launched a system called Bonfire as a sourcing and bid evaluation system. So next slide.
I have a question.
Oh, sure.
About the language interpretation services, how many languages are we faced with providing interpretation services for?
I don't know the answer to that,
county.
and Shannon's not here today.
Right.
So if I could follow up with you on that, nobody has that? 100?
I know. So we have a service rate.
The service is capable of doing hundreds of languages. We probably have a main like 5 or 6 that kind of are the most common.
Top 5 or
Yeah.
6. Okay. It'd be good to know the top 5 or 6.
Okay. Okay. Next slide, please. The next pillar is on workforce and being led by Carrie Premick-Volk. And, number one is increasing talent acquisition, or in other words, hiring people, reducing turnover through retention programs, and advancing performance management and learning programs. So since I was last here in February, or really this year, we've hired 130 net new positions since December. The HR has also established programming aimed at retention, especially as people start with our organization, to help them navigate the organization and be more successful here. Nursing has done a fair amount of work related to training. They trained over 250 nurses at a nursing skills fair. We've been reaccredited by the ANCC for our APRN fellowship program, and we also have a second cohort starting of nursing students in a 14-week health practicum. HR has also worked to establish an EMT apprenticeship program, and that the program is initiated with the first cohort starting in August. And finally, the JTDC, the Juvenile Temporary Detention Center, was identified as an outstanding training site for 2024 by the Association of Chicagoland Externship and Practicum Training. Next slide.
I have a question.
Mm-hmm.
may not have the answer, I'm just curious. Oftentimes we have public testimony and comments are made, and there seems to be a concentration of comments being made regarding nursing and retention. How do the strategies that you referenced here impact those statements? Because those statements continue to come. I recognize at times there's posturing that's going on. And maybe that's all of the cases, but I'm just curious because we have a constant rattling of sabers.
Yeah, I guess what I would say is it's, you know, our largest, staff population, nursing. So, you know, the likelihood that there is some issue that bubbles up, that's the largest group of staff. I do think, I don't know if Bina or Carrie wants to opine on.
So it's, I believe Bina's gonna do a dive into nursing, and we actually have retention
Oh,
numbers in
okay,
there. So yeah,
all right,
yeah.
okay. I'll yield to Bina Peters on that.
Yeah, I have a question about the EMT apprenticeship program.
Mm-hmm.
This is our first cohort, and we don't have ambulances, so we're training them to work with us or be deployed elsewhere, or?
I'll invite Carrie Primick-Volk.
Good morning, Carrie Primick-Volk, Interim Chief Human Resource Officer. So the EMT apprenticeship program is a grant-funded program. It was a grant provided to us by the Department of Labor, and it was to establish a program to work as a pipeline for us and other agencies or hospital systems and ambulance companies specifically. And we actually are partnering with an ambulance company to do this, and they are in the area and service our communities.
So the goal is to train them and get them through training and action.
Correct. And we actually also have positions, although they are not paramedics that work in ambulances, we have EMTB licensed and EMTP licensed individuals that work in our organization as well. So those positions would be available to them if they are vacant at the time they complete this program.
And training starts in August. When is it going to be completed?
So it is a 12 or 16-week program. I don't remember the exact number off the top of my head, but it is a day. They show up daily from 9 a.m. to 2 p.m. and go through the rigorous training course that they would need to get certified at the end of that course, and it lasts several months.
Yeah, it'd be interesting to know what happens at the end of the program and what happens with the.
Absolutely.
Who is the ambulance company that's our partner on that?
I will have to get back to you on that.
I know there's a few in the area, and then,
We do have a contract with that company already.
okay.
Yeah.
Is it a DOL approved apprenticeship program, or is it a apprenticeship program that we created that's being grant funded by the DOL? There's DOL approved apprenticeship programs that go through the Bureau of Apprenticeship and Training. So
This is a grant provided by the Department of Labor, and we created this program specific. It's not one of the approved programs through DOL.
okay.
Can we have a list of the demographics of the cohort? I recall when this was mentioned a while back, and it sounded extremely exciting. And I thought it was a great way to impact all of the communities and give opportunities.
We are currently tracking those metrics right now. So yes, once we have that cohort started, we know exactly who is going to stick with the program. We will be tracking and can present on all of that.
Thank you. I would look forward to that. Thank you.
And just to take a step back, the top 5 languages for us are English, Spanish, Polish, Arabic, and Ukrainian. And we have interpreters for Spanish and Polish, but we use the language line for the others.
Thank you.
Mandarin didn't make the top list?
Not the top 5.
Wow.
All right. So let's go on to the next slide, which is human experience. So this pillar is led by the Chief Experience Officer, Ling Dang, and it has 2 basic strategies. One is employee wellness and engagement, and the other is patient satisfaction. Under employee wellness and engagement, you know, we host a Patient's Choice Award event, so that recognizes staff based on obviously the patient's choice. And we also expanded the years of service recognition, or the participants doubled in any case for 23 and 24. And we are imminently going to be launching the employee engagement survey next month in June. For patient satisfaction, County Care has done some work for their members as it relates to adding lift options, conducting surveys to measure satisfaction. Stroger and Provident both have improved HCAP scores by providing inpatients with welcome packs to address noise complaints on the floors. You may have noticed some wayfinding signage has started to be rolled out. The phase 1 has been implemented and more to come there. And there was a survey launched for the patients as well through the Outpatient Ambulatory Surgery Consumer Assessment of Healthcare Providers and Systems. The Yacker trackers, that's kind of intuitive. It's a way to flag if it's starting to get noisy on med-surg units, and it sends signals to the teams to quiet down and attempt to have it be a quieter, more healing environment. So those have been expanded to additional locations. Next slide.
Yeah, I'd be interested in getting, over time, more information about the lift options that are being provided to members, and see if that has improved, people coming in for appointments, being on time for appointments. Be interesting what this does in terms of being able to get members in on time, keep their appointments, versus the cost of providing.
Yeah, okay. Next slide is fiscal resilience, and this is led by the CFO, Pam Cassera. The first one on here is continued implementation of the revenue cycle turnaround plan, reducing the reliance on agency and overtime, driving productivity to align with benchmarks, and streamlining invoice payment processes. So some of the progress to date, the year-to-date revenue collection is higher than budget, which is the ultimate objective of the revenue cycle turnaround plan. More to come there in terms of the implementation, but that's a good key result for that. We've established an approval process for agency staffing to help control spend, and we've also established a review process to confirm clinical effort expectation for physicians as the beginning of the alignment on productivity. Next slide. This is the optimization pillar, and this is led by Craig Williams. And there are 4 strategies listed here: expanding value-based care, modernizing infrastructure and equipment, maximizing access, and increasing surgical volumes. So on the first one, we've actually, and you'll hear more about this later, we have signed a value-based care agreement with County Care and CCH as a provider. So that's our first one, and we're looking to enter into additional value-based care agreements later this year. On infrastructure and equipment, we finalized the 2024 capital equipment, capital improvement plans. We've started to see some of those purchases coming to fruition. For example, CIRMAC has replaced a significant amount of their pharmacy equipment. We've implemented the mobile MRI, and we have other things coming online, but those are starting to happen. For maximizing access, we launched Express Care, implemented a new referral management software. We were monitoring the wait times for specialty clinics, and we decreased those by half, the wait time. We still have some work to do there. And we also decreased our external referrals by 26%. So we keep more of the referrals in-house. We've also implemented telehealth, home visits for CCDPH nurses, added a new endoscopy capacity at Provident, and also implemented teletracking features to improve patient throughput. Finally, on surgical volumes, we've updated our financial clearance process to reduce cancellations. We've been doing a number of things at Provident to reduce cancellations as well, and they've already seen a 20% reduction in cancellations over the past several months.
With Cook County Express Care, is that our version of urgent care and an opportunity to actually divert patients that are inappropriate for an emergency room to another source of care?
It's virtual, but so it's not. We haven't yet. We are planning on establishing urgent care locations, but this is exactly reflects the goal that you mentioned. But it is virtual.
And has it been promoted so people? Is there a line that people call or a website?
Craig is going to join me.
There's really two ways that people can access it. So when people call our scheduling line, there's an option that they are directed directly there. If they have an immediate need that we can't get them in time to solve, we direct them there. And then we've also been marketing after visit. People get a pamphlet on Express Care so that they know that they can access those services. We've actually also used it with our new arrivals population. So many of the shelters have that information, and new arrivals have been able to call and get care on, in a direct way.
How long has it been in place?
We went live right at the beginning of November.
Okay. So you have some data.
We do. The data is, to be honest, we're a little bit disappointed with the volume we've seen so far, and so we really put a full court press on that first thing I mentioned, which was getting people directly from the scheduling line to Express Care.
Okay. Maybe something you may want to promote that might increase.
Absolutely. Absolutely.
I have a question about the 20% reduction in cancellations at Provident. Is that in surgical?
Yes. Yes.
Okay, so from this seat, that sounds like a pretty awesome achievement. My question is, do we have an understanding of how that impacts the bottom line? Because it has to have an impact.
Certainly. I mean, surgery is positive for us financially. And to have a really high number of cancellations creates all kinds of inefficiencies, right? So, but are you asking like how much per surgery, or like how much that 20% equates to?
Well, I guess the overall thing that I'm trying to get to, we have it as a line item inside of there. But again, I don't profess to know, that's why I'm asking. But 20% sounds like a pretty big number, and we kind of brush past it. But it sounds pretty awesome to me. Again, I don't know, 20%.
It's pretty awesome, but I will say that we still have a ways to go to be happy with the cancellation number. It still needs to come down quite a bit. And, this is how we're working to try to meet the budgeted target for surgeries.
Duly noted. Thank you for that. I can appreciate your stance very much.
I have one question. I'm big on acronyms and other things, I'm not sure. But under the same line, surgical volumes, we have updated process to ensure financial clearance prior to schedule. I'm sure I know what that really means, but I'd like to.
Yeah, so to make sure that prior authorization occurs and that there isn't a same-day cancellation because of no prior authorization.
So, and there's ongoing kind of process improvement work around kind of the perioperative services at Provident. That's where we started, because there were higher cancellation volumes there. So there's a few contributing factors. This was one of them.
Yeah, they're related.
Communication ahead of time, kind of the preoperative workup. There's a few other areas that are a little bit harder to kind of tackle than, making sure there's pre-op. It's a little more procedural. So we're working down there.
Thank you.
Great. All right, next slide, please. So the last, but not least, pillar is growth, and this is one that I'm leading, growth, innovation, and transformation. And there are two slides here. The first 4 strategies have to do with developing the referral network, doing long-term programmatic facility planning, continuing to expand our subspecialty service lines, and renegotiating and restructuring affiliation agreements. So we have some positive, progress to report on these. We have expanded our referral network. We've most recently entered into agreements with St. Bernard's, Humboldt Health, and University of Chicago. University of Chicago and St. Bernard's in particular, we're looking at ways to work with both so that we could accept referrals at Provident. And for University of Chicago, we've started a process for them to refer cardiology and neurology referrals to Provident, and they've been using our new provider portal system, and we've been working through that process. So that looks like that is going well. We've just kicked off the long-term facility plan, so that is an accomplishment in some ways, like the contract's done, we have the team in place, we're just starting that process though. So more to come there. For the service lines, and I use that term, and that generally we talk about cardiology, neurology, cancer, maternal child as the service lines that we're focusing on. So we did some work through the marketing team and service lines to develop materials to share with partners so they understand what services might be available. We've launched the podcast series, and some of that will support the service line marketing. We've launched internal transfers from Stroger to Provident to optimize bed utilization so that we don't have people waiting here for a bed at Stroger, and for lower acuity patients that it might be a suitable location to go to Provident. We've expanded some service line procedures in cardiology, neurosciences, and Provident has also benefited from some expansion within the service lines. For the affiliation agreements, we have finalized a tool that we're going to use going forward to evaluate affiliation agreements and how, what the cost benefit of each of them would be, to make sure that we are only prioritizing affiliation agreements for volumes that we, for areas where we have the volumes to support it and it makes sense for our organization.
Could I ask a question? So do we have a process in place prior to finalizing this tool? Was there a process or an alternative tool that was being used? Is this an enhancement to that?
No, it's been a little bit of a struggle for us because we haven't evaluated. There's a lot of ways to evaluate an affiliation agreement. There's a pure bean counter, like are we making money more than we're spending? There's also a pipeline element, like is it a recruiting tool to have a particular program? So we haven't had a standardized approach to evaluating the agreements, and so this allows us to do that, and it's heavily quantitative, but it does allow for some qualitative aspects too, like pipeline opportunities, for example.
Finalization of the tool, does that mean it has been implemented, or are you just agreement on the tool that we're going to use going?
We have started implementing it. We've, I think, have put 14 of our affiliation agreements through this tool. We're still, we have a ways to go to, do them all, but we've started.
You're out of
using
stock
it.
again.
Mm-hmm.
Thank you.
Right, next slide. This is the last slide. So there are 4 more under growth. County Care is working to evaluate various products that would, beyond County Care, I should say Health Plan Services is working to evaluate various products. So it's not, to look at going forward. ARPA-funded projects, we are, at the height of implementing and executing those projects. And the long-term growth plan for CCDPH, and also conducting 1115 waiver readiness planning. So County Care has started exploring potential new products. They've also been working on streamlining application process for CareLink, helping kind of bring some of that managed care perspective to the CareLink population. For ARPA, and I know this was a big topic of conversation in February, if you recall, we have $170 million award from ARPA, and we've spent $40 million of it. We've obligated 62, and we are, I think, well positioned now. A lot of contracts since February have been finalized. A lot of hiring is pretty far along in the process. And so we're hoping those numbers continue to climb. But this, you may not recall this, but the ARPA award goes through 2026. So that's how long we have to spend the $170 million. So I think where we're sitting today, we're on a pace to do that. One thing that we weren't sure of when I last reported to the board was whether or not we could keep direct service positions on ARPA, and the Treasury guidance has come out that we can. So that allows a lot less disruption in what we were originally planning with the ARPA programs. And CCDPH, the growth plan is underway. They've initiated an assessment to really identify where the gaps are, what the capabilities are, and where we should go going forward. So I'm sure we'll come back to this board once we've completed the kind of further internal review of that. But the goal of this was to really establish a public health department that's ready to meet like the demand for services and public health work. We have started the project for waiver readiness. If I don't know how many of you are familiar with the waiver, but the state of Illinois requested a waiver, a Medicaid waiver from CMS, and it would allow us to invest in a number of social drivers of health, like housing insecurity, food insecurity, but it would also allow us to get coverage for some of our justice-involved population, so 90 days prior to discharge. And we have learned from the state that they're in negotiations with CMS to be concluded. They thought sometime in June, probably summer is the better, less precise expectation. And they have indicated that they want to start with working on the justice-involved population. So we have started an internal project to make sure that we're ready, that because historically we haven't billed at CIRMAC, and there's some complexities with the 90-day prior to discharge rules that we're working through. So that has started, and hopefully we'll be ready when that waiver goes through.
Could I go back to ARPA? Sorry, that was fine, just clarity. So we spent 40 million, I believe you said, obligated 62. So in total, would that be spend plus obligated 102, or is that 40 million spent also in that obligation?
Yes.
Because it makes a difference from the 170 down. I like that.
Right. 40 is part of the 62.
It is part of the 62. Mm-hmm. Okay. But going into 2026, is that a mid-year, year-end, when the deadline is to have these funds
It's the end of the calendar year for 2026, so December
So we still have a
2026.
full 2 years plus.
Yes.
And you're feeling pretty good about where we are.
I am. I think the only caveat is there's 140 positions on ARPA, and we have 70 that we still need to fill. That's going to be where the intense effort will be now through September, because we have to fill those this year in order to stay within the guidelines. So,
I think that's where my question is, because I thought the 26th was the completion, but there's something before that we're running up against.
yeah, exactly. There's there's a deadline at the end of this year to have hired any positions this year, and the county has requested that we try to fill all the positions by September 1st, because rightfully they want to make sure that we're going to spend the dollars, and so they need a little bit of time if we need to repurpose the funds to something else if we're not successful in hiring all of those positions. So we have until September on those hires.
Could we, of course, I know we talked about this last several months ago, could we have a monthly update on where we are? I'd be interested in
Sure.
tracking that progress.
I'm actually very concerned that we're not going to hit it, because we're here at the beginning of June, and we haven't had any reports stating that. I don't have confidence that we can hit it, because there should be an absolute plan to show us how we're going to accomplish that. To miss that opportunity would just be, to put it kindly, not so good.
On the personnel or just overall?
The personnel, because that's the first hurdle that we have to hit. If we miss that hurdle, the rest of it doesn't matter.
Right. So I'm pleased to share that many of the positions are well into the hiring process. So it's not like we're starting today. There's some positions that we're just starting today. So that we know that there are a few that are at risk. But we can certainly provide a monthly update on that.
That would be very welcome.
Yeah, I think that, back to the HR committee as well, that would be helpful, right? Do that. But that's a good mechanism. Sure. Card.
Yeah, I have a question about the Foundational Public Health Services. I'm familiar with the Public Health Accreditation Board, and I know that Cook County Department of Public Health is nationally accredited. So has this something to do with our accreditation?
I'm going to ask Dr. Hasbrook to join me.
Good morning, and thank you for the question. So, the Foundation of Public Health Services is basically kind of the gold standard. It outlines both the areas that local public health should be focusing on, as well as the capabilities that they should have. That is something that is sponsored and endorsed by FAB, the Public Health Accreditation Board. It's not required per se, because every local health department has kind of different capacity, bandwidth, but it is kind of the gold standard. So what we're in the process of doing, we just wrapped it up. We're kind of polishing up our report. University of Minnesota has a public health policy workforce think tank, if you will, shop, if you will. And so we commissioned them to do what's called a cost and capacity assessment for our health department. So using our financials, using our staffing footprint, and all the rest, they have completed a report that says, based on reflecting on the Foundation of Public Health Services, what should your cost for staffing be? How many FTEs and PIDs in our language should you have, and what should be the cost of that by these different foundational capacities and areas? So we'll be able to see what our deficits or gaps are, as Andrew said, in various different areas, capacities, and in areas such as MCH or communications or the like. So we'll be able to see what our net deficit is, and we're anxious to share that report with this body as well as the commissioners. And I don't want to I don't want to give you the bottom line first, but there is a gap. And that gap is delineated in terms of both people, but also the cost of those people. And so we know what our delta is there in order to kind of meet the bar as to what we should be doing given our mission.
How long is the process?
Process for what?
To actually go through this, is it a year, is it 6 months, or how long does it take?
That's going to depend on us. We're going to make the case and present what those deficits are. We're going to prioritize the deficits that we'd like to fill. And that's going to be up to this board and others in terms of the support that we'll get in terms of the budget, in terms of upsizing the health department. But we'll be able to tell you what that delta is and what our priorities are across these different capacities.
Okay, thank you.
You're welcome.
If there are no other questions, that concludes my report.
All right, thank you, Andrea. I think we're going to go to Dr. Beta Peters for nursing update next.
Good morning, all.
Good morning. Good morning.
Today here, it's an exciting day for me to present the multi-year nursing report to our Cook County Health Board. The report is actually on your table, and this report serves multiple purposes. One, since we are starting on the nursing excellence journey, an annual report or a multi-year report is a requirement. So really highlighting the excellence of nursing here at Cook County. This particular report takes us back to the journey when we declared our nursing excellence journey in 2019. And from there, it is very important that the nursing really come up with the data and benchmark for the nursing quality care we deliver across the system, and those are highlighted in the report. When we talk about highlighting the nursing excellence, it is truly the highlights of our excellent Cook County health nurses across the system. So that's one of the major part of it. Number two, also, this report also show the strong support of our whole health system from the CEO to the board. So I always say the board has a special passion for nursing, and also without your support, we won't be able to achieve this. Next slide. In this particular report, you have a table of contents that talk about from a quality, the workforce, and also the process what we use to do a strong foundation for nursing, and talked about nursing excellence, different part of it, as well as we also talk about the future, about where we are going. Next slide, please. And again, this is just to highlight this report. This is a copy of our highlights. This page is taken from the report to talk about the foundational work we did for the past 3 to 4 years to bring the nursing at the level where we become one of the best in the country. And that is demonstrated by the nurse sensitive quality indicators that we benchmark through ND and QI for the acute care. So that's really tell us, where we are going. And also talk about some of the structural process we put in place from a nursing finance, understanding the finance as well as be accountable to the nursing workforce strategies and also the quality and the other pillars. Next slide, please. So also we talked about where we are going. I know Andrea mentioned about the nursing excellence journey. Our goal is to go for pathway to excellence. That is one of the national designation. And that particular pathway to excellence talk about quality, the structure, and the process, but a huge focus on work environment of the nurses and the healthcare team. So we'll be focusing on the staff engagement, the work environment, and that include how do we integrate the technology, optimization, and the top of the license to really drive and provide a cost-effective quality care across the system. Next slide. So again, what do we do, right? This report is presented to the board today, and also we will share a copy with all the nurses across the system. And also we will post this report because those are all the requirements that we need to build in as we are bringing, our journey to excellence. And then starting this year, we will have an annual report. So that kind of, today's nursing report is short. However, it is condensed in this report, as well as the board members heard this throughout the last 3-4 years, where the nursing is going. I know Director Robinson, you did, had a question regarding nursing retention. So I'd like to comment on that. Nursing leaders, we started a nursing retention committee, it's almost now 3 years. And so proud to share that our nursing retention is measured by nursing turnover. And national average nursing turnover is close to 20%. Actually, it came down a little bit in 2023, which is 18.95. However, our Cook County Health nursing turnover is below 10%, which is, we are one of the top 95th percentile performers. And I had an opportunity to look at the data for this 2024, and that is closer to 7%. So we're doing really well from a retention perspective. However, we do have a high rate of vacancy compared to national rate, and also looking at the hiring velocity. So those are the two items. We are working with our HR partners to really, bring down the vacancy rate as well as our hiring velocity.
Again, thank you. Okay, thank you. And on the below 10%, we got. It makes it really difficult from this vantage point to try to give good comments to understand what's happening when different organizations give testimony. And so it would be like as if we're not doing our job if we don't ask certain questions after hearing certain comments. And so that's where it makes it good. And it's always, I guess, a point that we really would like to be able to get a majority of the people on board with, yes, we're doing a great job. The vacancies that are there, they're there for a reason. The agencies are being reduced as much as feasibly possible, and the overtime opportunities are being presented. The reimbursements now, that could be for tuition, whatever the agreed upon statement is, then to try to honor that, such that the grievance can go away, to try to make this a better place to make nurses want to come, because there's great work being done here. I don't think anyone can ever argue that point. The key is, how do we get that to transition through the entire organization to make everyone acknowledge it out loud so that we can attract more people, better people? And that's where my questions are really generated from, trying to find a way to bridge that gap between what we're hearing versus what's actually being experienced.
Well, can I interject? All things can be true. I think that's important to know, because I sort of sit here, I'm on the finance committee. I've been very supportive of the progress that we've been making on filling vacancies and prioritizing. But also at the same time, the criticism we get, and we'll just say when NNU or NNOC, there's the same organization, come in and they're critical, their members come in and their stewards come in and they're critical of things that are happening. Some of it's at the operational level, so it's not necessarily all the metrics that we're seeing here. Sometimes it's on staffing, but it's about discrete departments, because what we're seeing here is overall progress, which I think is great. But all things can be true. We can be making great progress. I think Bina's doing a phenomenal job, but we still have gaps in certain areas. And this is a complex health system. That how many nurses do we have, Bina?
Close to 2,000.
Yeah, and working in how many different operational departments?
Oh, more than hundreds, right?
So all things can be true. I also do think that the nurses who work here, who are even critical, believe that this is an important institution, and that we've made progress. But they're generally, there's been times where they've communicated that. When they come to talk to us is when they're looking to escalate on a problem that they're not getting solved through their supervisor, through the department, which is complex and is usually more than just the nursing staff impacting what's happening in that workplace. So I just want to level set that all things can be true, that we can have issues, like do anywhere, in any workplace, and we can also have successes and making progress. So I appreciate what you're saying, Sam, but to me, I'm hearing it as like an either or, and I just don't think that this is an either or type of situation.
Yeah, one
I'd
other
like to
thing.
okay.
Yeah, one other thing to provide perspective is we are a public entity. Rush, Northwestern, University of Chicago are all private, and they don't have these discussions in public. But I can guarantee you they're having these discussions behind closed doors, because the problems we're having are the same problems that they have.
Yeah. Well, I like that, I think all things can be true. And I don't think, Director Robinson necessarily was being disparaging in that way, or critical. I've been on both sides, public and private, institutions much larger than Cook County, and on public as well. But I don't want to get in the weeds on this, but what we hear sometimes are things that I've been hearing for quite a period that don't appear to be closer to solution. And I'm just going to pick one, and then I'll move on. What I heard this morning was this reimbursement issue. People who have ostensibly completed what they were expected to complete, a reimbursement coming. And I don't understand, I haven't understood what this time period is for getting those types of things done. The worst thing, second reimbursement, is not getting your paycheck on time. When you put in the time, you've done the work, there's an expectation that those things will be addressed. And maybe they have been addressed, but that's not what I have heard over months. And so I'll step back out of it, but it's that type of thing.
Let me invite Terry, my partner, in here, because those are the processes happen, HR side, so.
It just undercuts sometimes some of this great progress that we are making, and that seems to sometimes overshadow that.
Absolutely. And largely and a big part of the problem, like the back pay issue that we've heard about.
All of them, yes.
Right. And it's a larger problem than just Cook County Health. It's also, we're part of we're a big part of a bigger system too.
And I think that's been the tough part to navigate, is because there's that additional kind of layer of operational.
Okay. So we have an update?
Yes, Carrie Pramick-Vogt, Interim Chief Human Resource Officer, specific to the tuition reimbursement, which does coincide with the retro reimbursements that were related to the increases over this past year. It is exactly as Director Ryder indicated. Being part of that bigger county system, we are doing our piece. We try to keep those members informed as much as possible, but delays happen. We have been actively engaged with the finance and budget teams here and Cook County to resolve those gaps and delays, and they are working through system enhancements and upgrades to do that. But until the full enhancements are implemented, there's still going to be that delay, and we are trying to keep everybody as informed as possible, but being part of that bigger system is really what's at issue here.
So I have a question.
Yeah.
So what is the average time for a nurse to get back pay from when they've got it? Now,
Back pay in which?
like for the retro back pay, the things you pick it, or tuition, if they give it, what's the average time now? What are we getting now? And has that improved over some period of time?
Well, remember though, this is an issue that comes up like every 3 to 4 years, so it doesn't happen on a weekly or annual cadence. There's a triggering event every 3 to 4 years, and then I just want to level set up.
Yeah, no, I'm referencing the fact that the.
Well, how long has it been since they got their back pay?
Have they got their back pay? Yeah.
So generally, all of them have been processed, and 95 to 98% of them have received their back pay. There were some due to technical issues with the system and their particular journey in our Oracle system that created us to need to take a look at errors that were popping up, and so those are being handled separately, and those are getting worked through the process along with all the other individuals that were impacted in such a way. And so there's a very small percentage that have not received their back pay just yet, because it's a double manual process between us and Cook County proper. And so, but most of them have received their back pay.
And the average time to receive that was what?
That we don't know what the average time is, because every case is different.
It'd be good to know.
When this is probably an easier way to ask the question, get the answer.
Okay.
From the time the contract was settled and approved by both parties, when did the first
For NNOC specifically, to complete it, it was 6 months. It got started in 4.5 to 5. For incorporating all the various unions and all of their contracts, which is more than just the one, we began within 2 months.
So, and I will say, one of the structural challenges with this is the way that we do it manually, right? Or not we, the county does it. Because back pay has to be calculated. When you settle a contract, there's different levers of money that, for premiums and things like that, or job duties. It's not just, there's one line for pay on nurses and how many years there is. There's even more layers like you have in any system, and to do back pay for all those people at once, it's an archaic system. Part of it, I think, is the thought that people get fearful of moving away from it is the accountability factor to make sure that the wrong box isn't getting checked, the volume of employees. But I think references before that it is a very archaic system, and I think there's a lot of sympathy to people, like, when are they getting their money?
I would say that's the case, yes.
Yeah, and, this is, as someone who deals with this, representing labor, especially with public bodies, it is a very frustrating thing for employees of, large public employers and even smaller ones. It takes 6 months to get their back pay.
So you're telling us that this information is on paper and someone has to physically do it? They cannot go through any kind of computer system?
It's not on paper, it's on computer, but one employee,
manual.
you can have 2 employees working alongside of each other. One is they're on a steps, they have a steps or something. They can be on different steps. They could have different responsibilities in the unit. There's probably shift premiums that are at play. So it doesn't mean that because 2 nurses, when you walk in there, are working in the same unit, that their pay is the same. And you have to make sure that you're identifying each person individually. You would think that once they're coded as an employee, this is the part that I don't always get, is they're already coded as an employee in the system. You should change that number in that category, and that should then trigger everything else that happens through the system. But I think, and tell me if I'm wrong, Carrie, I think that then, after they go through that, they verify that all the proper boxes on the system have been checked, so someone's not getting less or more than what their unique pay schedule should reflect.
Yes, and the more manual part of the process, there's an automated process up front in the first half of the system, the one system, but our systems are not all the same, owned by the same vendor. And so we have systems that have to plug into each other. And the 2 of our systems that don't plug into each other for a full match of automation would be our employee system with our time and attendance payroll system. So those 2, that's the jump from we've done the calculations automatically through our employee system, now have to manually get transferred into the payroll system itself.
So Angela, this seems like this is a fundamental problem.
So if I could jump in for a sec, while not an immediate fix, so I know it won't be very satisfying in the moment in terms of an answer, we have implemented our dyad partners at the county level. We're meeting now to align these systems, to align kind of a roadmap to get all of this working a little better. So there is, a plan in place. Again, I know it's not something that's going to start working tomorrow, but.
And that's the other thing, that we only have so much control over that, because the checks that get cut, if we were employees, our checks would say County of Cook. The Cook County does the bank transfers and writes the checks.
That is correct.
We don't do it.
And owns the system.
They own the system. Let me read that 1 second. Director Garza had a comment. And then...
Yeah, so Carrie, you and I spoke a couple of weeks ago about the back pay on overtime, and it sounds like there's been progress made to condense the timeline on that. And I understand whatever the infrastructural challenges that you have to deal with the greater system, but I guess I gotta ask, what's the expectation we set with the employees? Like when they're either in an overtime situation or tuition reimbursement situation, that this could take 6 months or longer because of the mechanics. I mean, I don't think employees care about the infrastructural issues. They care about being paid. You know, whether it's a benefit that they're subject to, they're eligible for, or they've done the work, and they want to be paid. None of this matters to them, really. They just want to know, when am I being paid for the work I've done? So what's the expectation that we're communicating with them so that they understand going into this, that it could be a 6 or 7 month, whatever the timeline is?
When they complete the paperwork, there is a timeline of how many pay periods they can expect that this will take, which historically has not been an issue. But this, over the past, I want to say, 1.5 to 2 years, not just CCH has been experiencing issues around this, which is why county proper has gotten involved in the reimbursement process of it. The overtime issue that they brought up is actually not a pay issue. It's an access issue, which is related to the competency testing, which, you know, we talked about how we went through this whole competency training and things of that nature. So that was more related to making sure the people getting the overtime were competent in the areas they wanted to perform overtime in. So it wasn't really a pay issue.
Okay.
And so, yes, we have been partnering with nursing to assist them in implementing that competency check process and implementing that new process, just to ensure that we're giving that safe patient care and that each nurse giving that care is competent to do that particular type of care. They may be competent in the area we've hired them to be, but not necessarily in that overtime area they want to work in. And so that's the gap we've been trying to fill with that, which we're going to be implementing the new solution imminently.
So are
There was
they
another
aware
part of that question that I'm missing, though.
No, well, I guess.
The expectation set, yes.
Yeah, well, yeah, that's exactly what it comes down to is, what are we saying the timeline is, and then have we gone beyond that results and the testimonials that we're getting at meetings like today, which the last lady spoke about, travel reimbursement. I mean, just generally a disgruntled feeling in the relationship between nursing and HR staff. I mean, it literally called for a vote of no confidence. And I just want to know that, at least fundamentally, while we're trying to resolve the greater issue of how these things are processed, that there's, to use your statement, that there's level setting happening with the employees at the front end of the experience.
Yes, and then we are following when that gap starts to occur, the issue starts to occur, because that issue doesn't impact each and every person. But when it does start to impact those individuals, we do respond to them and follow up with them to explain that, you know, we have submitted certain things and they're in certain stages, and then we try to work with them and update them as frequently as we can.
Yeah, I would venture to say, and I'm taking a step back, if it were me and I were in the situation, I would not care what the problem is. I would want my money.
Exactly.
And I think that's what we're hearing.
Well, that's basically what we're hearing, and I basically agree. So,
That is the problem, and, you know, the distinction, one of the things I always like to put on the floor when this stuff happens is that there's accountability all the way around. We don't completely own the system.
we don't, right?
But we have to also be vigorous advocates for the system to get fixed and realize exactly what Joe said and what I think I've heard Lyndon say, is that people don't understand. They negotiated a contract, they voted on it, they went through the whole process, and where's their money, right? Where's their money? Because they don't get an interest payment based on the back pay. Correct me.
No.
I'll try that people work down, kind of like they do not. No, I mean,
And they'll remind us of this.
Right.
So I've actually been out there, where's my interest? You know, when I'm on the advocate side, that's what I'm saying.
But they do pay interest if they borrow money to get their degree, and now they are looking to pay it back, and they can't pay it back because they haven't been reimbursed.
Exactly.
That's a fundamental issue.
And so, yeah, I think what you're hearing, we recognize some of you don't, but, I don't know. Look, I've been on this board for 3.5 years. I think I haven't had a board meeting yet, 4 years, actually, next month, where this has not been an issue. And so what we're hearing about, there's some part of it been an issue. So I think what you're hearing, I'm sure all the other directors are saying, kind of this, the frustration around that. And I think what you're also, the frustration there, because we also are advocating for the system. We are advocating for the people. And so what we want you just have to be in the middle of the room now, because of this, is to recognize that. And I think what we need to do where we can, to be, and you, is, you know, we have general, what we've asked is specific questions and got general answers. We need specific answers for the plan.
Well, we can't.
No, I got that side. I'm talking about our side.
Right, so that's,
Okay.
but.
And that's what I think we need to understand, our side.
But that's what I was about to say, is that, we can acknowledge that we don't control everything, but we can acknowledge we have a responsibility and that we can't just say, it's not our problem.
It is our problem.
100%, 100%, we agree. So we need our plan. All right, thank you.
So Angela, are all of our systems communicating?
All of our systems are communicating, and the manual component that she talked about applies to specifically retroactive pay for the 2 to 3% of people that she had said had issues. So the systems are integrated when the retroactive process for the complicated solutions that she spoke of, I think she said 95 to 98% of them are fine. But for that few percentage of employees, there's a manual step that HR has to do. The systems are integrated 99% of cases outside of this retroactive. So it's not just systems, it's processes.
But that also raises the question that if it's only that small percentage with the system's not communicating, then we shouldn't be at 6 months on getting retro checks out.
I'll let Carrie speak to the process.
Listen, I don't think some people can get there in 2 months. Let me direct this if I could. Let's bring it back, right? This is Deanna's report on where we are in the nursing excellence program. These are things we've highlighted now. We can go down a rabbit hole, and I'm guilty of that as well. Thank you. We recognize what we need to address in HR committee. We recognize what we need to address in QPS. We recognize the big problem. We recognize that we have problems that we need to address. Thank you.
Thank you.
All right. Well, thank you, Bina. Thank you, Carrie. Thank you, Angela. We are going to shift gears now and give an update on value-based care. I think it'll be both Aaron and Andrea.
Welcome back, Andrea.
Good morning, Directors. Aaron Gleaner, Chief Administrative Officer with Health Plan Services, and I'm here today to give you an update on really a flavor of our overall value-based care approach. It's certainly not an exhaustive review, but want to provide some high-level review of what our goals are, kind of where we are status-wise in our evolution of value-based care, and also provide some insight into where we're hoping to go. So the core function of our value-based care strategy is really to improve quality, as well as enhance the member experience and promote equity at the same time that we're able to do that within a financial model that makes sense and drives efficiencies. Where we're at today is we are a leader nationally, both nationally and then here in our local market, in terms of how much of our spend we have within value-based care arrangements, and not just any type of value-based care arrangements, but arrangements that are farther up the spectrum than most of the other plans in the market. So I'll talk a little more about what that means. We focused initially a lot of that work in the primary care space, but have evolved more recently to look more at opportunities in specialty care and other areas across the plan that continue to evolve and continue to represent really good opportunities for us and to help enhance the members' experience with us. What we've seen across our portfolio is that the outcomes for members that are in value-based care arrangements with those provider groups are significantly better than what we see just across our county care population generally. So we see a very clear impact of that, and I'll share a little bit of that data as well. And then looking forward, we're very committed to continuing to evolve around value-based care. As I mentioned, I think there's still a large number of opportunities out there, especially in the specialty space, opportunities with hospitals, and to continue some of that growth and evolution with our primary care partners as well. I'll go to the next slide. So we really align those value-based care approaches with the core Cook County Health strategic objectives. I won't read through each of these, but these really form the foundation of what we're trying to do as we think about our value-based care strategy. So this provides a summary of how much of our medical spend is covered under a value-based care structure. So the left-hand side is 2023, where we had, and both of these are in the range of 60%-ish across the 2 years, a little bit less in 2023. That's grown into 2024. But you can see we have about 60% of our overall medical spend that's under some type of value-based care agreement. The shading here represents how much of those are in certain categorizations. There's a standard model for how you categorize value-based care agreements called the HCP land model, and so they kind of categorize these on a spectrum of 1 through 4. 1 basically being fee-for-service payments that then have some link to a performance or quality bonus based on things like HEDIS measures, up to the far end of the spectrum, which is category 4, which would be 100% risk being provided downstream to the provider, again, with some requirements around quality. We, by far in the market, have the most category 3 and category 4 APM models within the value-based care space. And so, again, kind of represents locally as a leader in this space. When you look at the HCP LAN model overall, they kind of state as a goal or a target that Medicaid overall, they'd like to see get to 30% of value-based care arrangements nationally. And so we are already effectively at double that today. As we talk about our goals, we're really looking to move to about 75% of our spend to be in that category 3 or 4 model over the next 1 to 2 years. So that's the goal that we've set out internally and that we've represented to our state partner as well. I won't read all the way through these, but I just want to provide some viewpoint of the providers that we partner with that are in some of these value-based care opportunities. And in both of these situations here, we delegate care management down to the provider level. It allows those care managers to act as an extension of the primary care medical home model. It allows for them to unlock additional opportunities for care, for outreach, for managing that patient beyond the 4 walls of the health system that they're in. And so, you know, I think we get really, really close partnerships and strong results from our provider partners when we enter these type of arrangements. I also think county care is uniquely positioned in the market to be a leader in value-based care. And that's really because of a couple of core reasons. One is our scale. Locally here in the market, we have the most market share among Medicaid managed care plans in Cook County at 33%. And we are just focused in Cook County. What that means is that we tend to have a high penetration rate and a lot of volume with our provider groups. And that level of scale helps create the potential to really enter into some of these opportunities that if we had much lower scale with a broader number of providers, that those same opportunities would still be there, but would be much more complex to enter into, manage, build infrastructure around, et cetera. This is just an example to show some of the outcome differential that we see across the impact of our value-based care arrangements. So the county care column here just represents some of our HEDIS measures overall at the plan level across the entire plan, and then you can see with some blinded data for two of our value-based care partners, and these are two of our largest value-based care partners. So these, weren't cherry-picked. We just went with the two largest. You can see the differentiated impact on the quality data from the value-based care arrangements. So there's very clear improvements across the spectrum when we evaluate these arrangements, and that carries through generally on the cost side as well. But we see really great quality results, and we continue again to try to evolve these. We continue to put increasing emphasis with our provider partners on quality, and these aren't stagnant measures and metrics that we build into these agreements. These are things that change and increase the standard of performance that we expect from our provider partners, and that we can help partner with them in terms of what data and infrastructure we provide to help unlock that type of value for them as well.
I'm sorry, Aaron. How do those numbers compare to the other plans in the market, in our market?
So,
in general.
We just put our pencils down on the quality work that we've been doing this year, so we just submitted in our HEDIS quality data. I think preliminarily we are showing very strong results, but I think we'll be able to give you a deeper review of that as we come back, likely for the next managed care meeting, and then the official results will come out in September and October. Historically, we've been in the top 1 to 2 plans in the market in terms of our overall quality data, though. And I think based on what we're seeing this year, I think we'll have very strong quality results this year as well.
Okay, so my question is leading. I thought you were going to say I was hoping you were going to say we're at the top. The next question is, how can we take that and translate it over to the marketing side? Because I would like to see us dominate the market. If we have the better product, we should be able to dominate it. So now that means we got it operationally correct. Now we need to get it from the marketing side to get people to believe.
Yeah, absolutely. And I think we took advantage of some of those opportunities this year as we started to highlight more in some of our digital media, the quality ratings that we have across different categories. So women's health, for example, where we're rated as a 5-star plan. So we've highlighted some of that more recently. The state does put a little bit more restrictions around the way that we can leverage that than we would probably like, but I think there's going to be definitely continued opportunity. The other side of that I would say is I think one of the areas where we do have more opportunities for improvement is how our members perceive our quality as a plan and how they perceive their experience with us. So we get very good ratings when they just rate us on quality of the health plan overall. But as we get down to some of the underlying data, we do see areas where there's some differentiated impact in terms of how they feel about their ability to access specialty care, for example, or their ability to get needed appointments in the time frame that they perceive and their expectation is to get those appointments. So those are areas that I think all play into that decision about whether a member chooses you as a plan, and I think are areas that are opportunities for us. And so some of our strategies to pursue urgent care, to pursue telehealth, and we're doing that more and more in some of these specialty areas like behavioral health, for example, are all geared towards exactly what you're getting at, which is really being the plan of choice within the market.
Have you had a chance to have focus groups?
We do. So we do annual focus groups, and then we've also implemented over the past couple of years what we call our pulse survey. So every 2 months we go out and survey a subset of members, and it's a smaller subset, so it's about 100 members at a time. But as we've done that now for 18 months or so, we're able to really compile a pretty good data set and look at that data by geography, by age categorization to really understand also within the demographics of our population, how they perceive their experiences differently within the plan.
One thing that I've experienced, and that I recall about 20 years ago, with people who would be potential customers, to hear the conversations that they would have, and they would say, don't go with this particular company. They don't do X, Y, Z. So the objective would be to have them say, I'm really proud. Guess what they did for me? Guess what my company did for me? And if we can do that, we could really maybe get some traction, because I think the closest competitor is Big Blue. And of course, they have a huge marketing budget, but quality trumps everything after a point. Thanks.
I think you know a little bit about this area.
So this slide represents some of the newer areas that we've begun to focus on in our value-based care portfolio. And as I mentioned before, you really see the pivot from just the primary care space to now into some of these more specialized areas. So kidney care, we've just launched partnerships around behavioral health. We're now heavily focused on as a strategy for the plan, both last year and this year, and continuing to build and evolve around the behavioral health space. Oncology and cardiology is two of our highest cost areas, and areas that have a lot of opportunity for not just value-based care, but also how we can better streamline the different treatment pathways and how providers are able to receive information for us and leverage that with their patient population. And then orthopedics is another one that we've started a partnership with this year. And we'll continue to evolve, I think, particularly in the specialty area and also with hospital-based partners as our next evolution. So as we look at 2024 and beyond, we are looking to continue to execute on new value-based agreements. Primary care providers are always going to be a core focus and one that we look to partner with. And then, as I mentioned, we'll continue to look at different specialty areas. There's opportunities as well. I didn't mention this before, but in other areas such as home health and our waiver providers, nursing facilities, we have a large population of individuals that are in nursing facilities and long-term care, almost 30,000 of our members, which represents a large spend portfolio within the plan and also a lot of opportunity for quality enhancements as well. There is a need for us to continue investing in some of our core capabilities here, mainly around how do we create the infrastructure that can scale across having a broader swath of providers, as well as how do we help meet providers where they are on that value-based care journey. Not every provider is ready and willing to take financial risk, for example, straight out of the gate, but it's a model that they need to build to over time. And there's infrastructure that we need to help build to be able to provide some of that information to them as they're moving up that spectrum of capability that they have as a provider themselves. And then we are continuing to evolve how we evaluate the performance of those providers, and then how do we ensure we have really clear models on, based on X performance, we make this adjustment within the agreement, or potentially X agreements that we've entered into that we don't think we're seeing the kind of value that we would expect from. And then finally, I think one of the more exciting things that we're looking to build in and have begun down this path is how do we really think about equity within the context of those value-based care agreements. So how do we think about those outcomes? How do we build that into the financial modeling? How do we help provide those kind of supports for the providers and for our members under those arrangements that can continue to enhance quality, continue to close disparities in health outcomes, and how we continue to expand those collaborations, specifically around social risk factors and social determinants of health. And then my last slide before I turn it over to, or two more slides. So one thing I wanted to highlight was one of our core partners that we are excited to be stepping into value-based care with is our own Cook County Health system as a provider. So we've historically had some components of the different value-based care infrastructure with Cook County Health. So we've delegated care management, for example, to Cook County Health for the patients of the primary care clinics within the health system. But we've now kind of formalized that structure and wrapped the kind of full spectrum of the value-based care agreement around that in terms of defining clear quality priorities and financial incentives tied to those quality outcomes that we've listed here on the screen, as well as built in a shared savings opportunity based on total cost of care on a risk-adjusted basis for the health system and the primary care and panel patients of the health system. So I think Andrew will talk a bit more about that here coming up, but I think that's one of the things that we're really excited to continue that evolution within our system.
One moment. Director Bott has a question, so make sure we acknowledge it.
Thank you, Mr. Chair. Aaron, was just curious on some of the partnerships you referred to on specialty care. Is there discussion with those, are those partners involved in thinking about home and community-based services, to maximize the impact of value-based care?
Yes, absolutely. I think that's one of the areas we see as an opportunity going forward. I mentioned, I think we called it our waiver program on the slide, but that's effectively what we're referencing is home and community-based services, as well as some of the other waiver providers that are out there.
Thank you.
And then the final slide is here for reference. This is the standard model that I mentioned, the HCP land model, which is the framework for alternative payment models and defines between category 1 up to category 4. This is also the standardized way the state looks at the managed care plans and evaluates where we're at on our various value-based care programming. So again, category 1 is kind of the basic fee for service. Category 2 starts linking some outcome to specific quality in terms of things like pay for performance around HEDIS. And then as you go up the scale, it involves sharing risk or shared savings with providers until you move to kind of the far end of the spectrum, which is the full risk, integrated care delivery systems, et cetera. So with that, I will turn it over to Andrea to talk more about the Cook County Health side.
Thanks, Aaron. Andrea Gibson, Chief Strategy Officer. So we've had a productive internal partnership between County Care and CCH as a provider, and we're excited to be kicking off this value-based care focus. We've been doing some things that help, get us ready for value-based care, and we're in the process of setting up a better kind of structure so we have kind of methodical approach to addressing the things that we need to address. I will say, before I go through the slides, County Care and CCH as a provider, we've been meeting for the past several years and looking at metrics and where we need to build a strategy. And we've had a very productive working relationship. So I'm glad we've had a lot of good outcomes. For example, last year we increased the percentage of County Care members who are in care by 12% or something, 10 to 12% last year. And it was because of that partnership. And of course, now I think we're ready to push ourselves further on value-based care. So this is this wheel is this diagram shows like all of the things that we need to focus on, and there are guiding they provide guidance to us on which areas to focus on. So technology and digital solutions, quality and risk management, patient access and continuity of care, team-based care, medication management, nurse advice and triage, referral utilization management, and preventative visits and wellness. And some initiatives that have been underway for a while fall under this, but we're using this as a way to organize our work under value-based care. Next slide. So how ready are we? I mean, our goal is to use value-based care to improve population health for the patients that we serve. We wanted to address the health of our population, reduce costs, and enhance the quality of care that's delivered. We have been looking at what our medical loss ratio, total cost of care, is, and we see that MCOs typically set thresholds at somewhere between 88 and 90%. And depending on the population, in some instances, we are already meeting the threshold of the MCO. I think we're close on county care, but we're going to push ourselves this year to get there. So the finance team is taking the lead on negotiating agreements and, reviews how we're doing compared to the threshold that particular MCO sets. So next slide. So this just gives you a little bit of transparency into how we're approaching it. So we have set up kind of a meeting structure, created 6 subgroups with objectives and project plans and tactics and all that. And so the subgroups are care coordination integration, panel management and risk stratification, data, IT, contracting and rev cycle, and clinical operations and medical management, and education, and clinical and frontline operations. So we have teams under each of these to address the most pressing issues. Next slide. So as Erin mentioned, we entered into our first value-based care agreement with County Care at the end of April, and we have a process. We have a routine provider plan alignment meeting every month, and I mentioned some of the outcomes earlier when, we've increased the percentage of members in care through that that work in that meeting. And we have now folded in the specific objectives in the value-based care meeting, or in the value-based care agreement, into that meeting. And so we have, objectives and key results, and this shows you some, not all, but some of how we're setting incremental goals for each quarter, for each of the measures. And then during that structured meeting, we will work on strategies, first review how we're doing against the data, then work on strategies to meet the goal.
Irene is correct. On the first line on cervical cancer screening, see a baseline at 39%, but this Q2 goal is 28.5%.
Yes. It's a cumulative goal. So by the end of the year, we want to be at 57%. Next slide. So this is actually the last slide. So we are excited that we are structuring the infrastructure around this, and we'll look forward to coming back to you with some results. I'm optimistic about the one with County Care, and then Finance is working on finalizing 2 more agreements this summer, and then we'll continue to look for opportunities that make sense for us going forward. So, Dr. Makaitis, I don't know if you wanted to add anything.
No, that was very comprehensive.
Right.
I will, I think just in terms of kind of a go forward, in addition to all the operational and kind of care delivery work that's happening, we're also looking in terms of infrastructure to, it's very kind of exploratory right now, but creating an ACO within, so we have outside counsel helping with our legal teams to try to, create create that infrastructure, which would then set us on a path to be able to join Medicare Shared Savings Program as well, which is another contract potentially. But that would be about a year and a half before we'd be able to do that. So laying the foundation.
Good. I'm curious, with the value-based care, the numbers seem to be increasing. Can we quantify that monetarily?
Which numbers?
Cervical cancer, we can take first one, increased prenatal visit completion of the first trimester.
Yeah, so in a value-based care agreement, this would function essentially as a clawback. If you weren't performing well enough, it gets you in a position where you have to earn a certain amount of the shared savings pool. You also then have to meet your cost target, right? So you'll be targeted to a certain trajectory in the total cost of care. So for example, Aaron, where did we end up? 91% MLR? Yeah, so we have an upside-only agreement to where if we get below 91%, that creates a pool that we would then be eligible for as providers. So that's how kind of an upside-only would work. Now, if we don't meet our quality measures, we become ineligible for those. So it's kind of a two-pronged approach where you have to actually kind of bend the cost curve and actually, create savings by providing better, more coordinated care, but then at the same time perform well on quality. The thinking there is that you have to perform on quality. You can't just turn your lights off and not answer the phone. You have to take care of the patients, right? So that is, you can't just not spend any money to take care of the patients and then create a savings pool that way. It forces you to also continue to provide good care, right? So it incentivizes, right, those equitable outcomes that we were talking about, right, where instead of that transactional, we wait for people to come back to the ED, or we wait for, we just see them in office. It incentivizes us now to have a more longitudinal relationship with our patients, where we're more connected and they have better access to the care that they receive.
Eric Curry, what's your experience with medical loss ratio?
Well, first of all, I'm going to get on a mission to change to, should be medical benefit ratio. No, really, right?
I agree.
Yeah. Not an insurance, it's the benefit ratio. And we think of that like, well, I think what I was going to ask, like, get some of that. So in this first year, we just signed these agreements. Are there protections for us and for the providers? Are there any guardrails around what these expectations are?
Yeah, so we're upside only right now. So there's no risk there. We're using this as kind of a learning curve. It'll be the same strategy with MSSP. We would probably do the most conservative track, which would be a 7-year glide path to downside risk. So I mean, there's,
So
we'll have plenty of time to figure it out.
Those are the kinds of things, that's the experience that you want to see what happens in that first year so you can have the ability to make adjustments.
And I think the additional data transparency that happens once you get into value-based care contracts will help us learn faster. So that was the thinking as we're building the infrastructure, get into these agreements so we have more transparency to kind of learn a little bit quicker.
But overall, personally, very, very supportive of moving in this direction, and glad to see that we're out the gate and moving forward.
Great strategy, because clearly the industry is moving this way, so it's good to see us doing it.
Thank you.
Thank you both. That concludes my report.
Well, thank you very much. No questions. I'm going to say, Mr. Galino, you should stay there. The next item is a review of the Managed Care Committee metrics, apropos by Aaron Galino, Chief Administrative Officer for Health Plan Services. Thank you.
Thank you, Chair. I'll start with our usual metrics today. This shows our membership as of May 7th. We were at just shy of 435,000 members. This is the first month that we've returned back to some decline in membership, which I'll talk more about. But as you'll recall, we were bringing on the healthy benefit for immigrant adult population, which was exceeding in terms of new members the loss we were experiencing from members losing coverage from redetermination. So through the first few months of this year, we were growing, but expect here as we complete the final few months of this initial large wave post-pandemic of members going back through, that we'll see a couple more months of month-over-month decline in membership until we start to stabilize after we get through that large wave. The next slide shows our market share data. This is as of February, so it starts to get into the first couple months of us bringing on the HBIA, HBIS population. So you may recall this is an increase in our market share. We had been closer to about 32.3% prior to this, so it's about a 1% gain in market share, which is great to see. Obviously a smaller percentage, but I think important to keep in context that this is, on a basis of 1.3 million lives across Cook County, so 1% is still a fairly significant shift that's happening within the market share data. And we expect this will continue to tick up as we get the March and April data from the state. The next slide shows the Medicaid managed care trends from the overall market on the right-hand side, and you can start to see some of that impact that I was referencing on the left-hand side of this graph. So the county care in the blue bar, you can see that we were tracking very closely with the rest of the market through the redetermination process, but you now see the increase that we've had over the past few months as we've also brought on the healthy benefit for immigrant, adult, and senior population. So you can see the rest of the market has continued to shrink while we have started to grow over the past several months.
You attribute the growth to the HBIA and HBIS?
The next slide shows our membership in terms of our budget. You can see we're in a really strong position relative to our budget. As you may recall, we didn't expect to receive the HBIA and S membership at the time we were doing the budget last year. So our budget that was in the blue bars is expecting that continued impact of redetermination. And then you can see the impact that we've seen in the red bars. Two things really driving this. One, we've continued to outperform what our baseline expectation was and retention of members going through redetermination. And I'll speak to that here in the next slide. But then also, again, the HBIAS population that started coming onto our plan in January. So you can see January through April, we had month-over-month increases in the total membership. And then, as I mentioned, May was the first month that population that fully transitioned into managed care. And so the impact that you see in May and the decrease there is really driven by purely the redetermination impact. Two comments I also want to make relative to the HBIA and S populations, because there has been some policy changes recently. The first is that the states announced that they will be putting all of the HBIA and S members through a redetermination process themselves. And again, this is a population that's had some really major transitions in their healthcare coverage over the past 18 to 24 months. First, coming on to the state-funded program under Medicaid fee-for-service, most recently shifting into managed care, and now going through a redetermination process, which none of that population has gone through while they've been under the state-funded coverage before. So a lot of changes, a lot of transitions, and so a lot of effort that we're putting into the process for outreach and engagement. We've seen an overwhelming response to our outreach and redetermination events recently, as this population has started to receive their letters and has received communication for us around support we can provide them through this process. The state is putting the entire population of the HBIA and S members through redetermination all at one time. So all 35,000 individuals in our plan that we brought on January through April received letters right at the beginning of May about the redetermination process. So just from a sheer volume perspective, that's also a challenge that we're faced with. We've typically had around 25 to 30,000 members a month going through redetermination throughout this past year. In May, we are going to see, we're seeing almost 60,000 individuals going through redetermination between the HBIA and S population, plus the core Medicaid population that we still have going through this process. So from a volume perspective, that's certainly a challenge. I think from an infrastructure perspective, we're able to handle that kind of scale. Like, we're able to scale up our outreach, text messages, all of that relatively rapidly, but certainly that's a challenge, and there's a number of just underlying barriers that we have to help these individuals overcome to retain their coverage. So
If you have any chance to maintain this population, you must have a large population of Spanish speakers.
Yes, we've been heavily focused on that, both in preparation for when this population was going to be coming on. And I want to say it's not just Spanish speakers. To your question earlier about Mandarin, Mandarin is definitely in the top 5 languages that we see within our health plan, along with Arabic, Polish. and so, you know, it's an area that we've been heavily focused on as we were staffing up for this transition, and now it's even more important as we continue to engage with our overall county care population, not just the HBI and HBIS subpopulation within the plan. The second policy change that I wanted to highlight is that individuals in the HBIAS program that are legal immigrants, so both individuals that have been here under 5 years and individuals over 5 years are being transitioned into other programs. So that's about a 5,000 to 7,000 member impact that we're expecting will be transitioned out of our county care population and either onto the exchange if they have, if they are under that 5-year threshold because they qualify for federal subsidies on the exchange. If they are over the 5-year threshold, they qualify for the core Medicaid program, and so will be transitioned onto the standard Medicaid program. So some of those individuals may still stay within county care, but there is going to be a significant transition that's also happening here with HBIA and HBIS members.
Are there any rules that prohibit you from being able to directly solicit those individuals? There are, one of the things that we're still trying to get clear information on is exactly how that, that transition is going to happen for those individuals that are moving just into the standard Medicaid program, and whether they'll have to go back through a choice and enrollment process for MCOs, or whether they would just stay with the MCO that they're currently with. All right, the next slide shows our redetermination metrics, and this continues to hold fairly steady. I'll wait for this slide to catch up. So we've continued to be around the 84 to 85% range in terms of retention rates. So it's good to see that continue. As I mentioned, we're still a couple more months to go in this large initial wave of individuals, and then we'll be past this large wave and hope to see some stabilization here. The next slide shows our operations metrics, and all of these are within SLA, so no real call-outs here at this point. The next slide shows our inpatient admissions per thousand. I think, you know, the key takeaway here is that generally we've continued to see year-over-year decreases in inpatient admissions per thousand as redetermination impacts hits and the population shifts within the plan because of that. We're expecting what will remain will be a higher acuity population, and so we expect this trend will reverse and we'll start to see an increase in the inpatient utilization per thousand members because of that impact. Similarly, on the premium and revenue side, that should also adjust upwards to account for that, but that is one of the dynamics that we'll be watching play out financially over this next year. Is the reasoning for that because you think they've been out of care?
It's more that individuals that are more engaged and more likely to renew tend to be ones with chronic health conditions, and healthier individuals tend to be more likely not to complete that renewal, or maybe more likely to transition to the exchange because they're a working age adult population, for example.
Well, I don't know the percentages, but if I'm healthy, so I don't do my renewal, that's greater incentive for us to try to get them to renew.
Yes, it certainly helps us manage the overall risk pool within the plan.
So do we have a strategy to try to go after them, unless you're telling me it's a small percentage and it's negligible?
It's not a small percentage, and I think this is an effort that we're trying to attack on multiple fronts. It's not, I would say not even just the renewal, but that core competency of being able to outreach and engage with members across a variety of topics, including quality, is really critical. And we're starting to try different avenues, particularly for the younger adult population, especially those kind of between the ages of 20 and 30. Because that's the population that we see the lowest engagement when we do those outreach. So in terms of lowest engagement of those that are going to their PCP, lowest engagement in terms of those that are renewing their paperwork. And so that's kind of a consistent trend across the demographics. And so that's been something we've been focused on trying to build out, both in our outreach techniques. Text messages are, much greater ways to engage, specifically with that age group, as you would expect. Preferred language continues to be really critical. So a lot of the techniques are, I think, similar, but we're also trying to move to some specific benefits that speak more to that population. Telehealth is another example where we see much better engagement there. So
I'm curious, that age group, how long have you had them in care in general?
I mean, we've always had that segment of the population in our plan. Over the course of the pandemic, the proportion of that age group grew relative to the other age groups. So I don't recall exactly the percentage of that increase, but there was definitely a shift as you look at the demographics in the plan of more people in that age category.
Here's the thought. If you've had them for a while and you have a mobile number, but if you have that ancient thing called a home line, the home line might become very crucial because there's a tendency for the matriarch to try to tell certain people certain things. And that may be a way to get there without actually removing any information or privacy.
Yeah, absolutely. I think one of the things that I hadn't mentioned was it's one of the most effective ways to get engagement is often another influencer in that individual's life. And so I think that's one of the things that we've started to try to figure out ways that we can try to build that engagement.
Thank you. Chair, I'm sorry, I'm taking out this time because I recognize this is the engine. This is what makes it go.
The next slide is our claims payment turnaround times. And so I think post the year-end budget rollover, we've seen that come back down to what we'd expect. We're right around the 30-day mark and expect that to remain fairly stable. And then my final slide on the next one just breaks that down by aging category. Again, a lot of stability here. I think you've seen the main variation now in that 30 to 60-day category, and that's really just based on kind of the weekly payment timing. So as the payment hits, it basically wipes out that category. We're trying to continue to get that a little bit better, but I think we're in a pretty good position there. And with that, I'm happy to answer any other questions. Thank you.
Thank you very much. Make sure where we are. Put me off now.
I'm just hearing.
I'm not with you. We're all good. We're all good. Good questions, Director. Good engagement today. The board will be going into closed session today. Action is not expected to be taken upon in the open session after the discussion in closed session. Therefore, I'd like to entertain a motion to go into a closed meeting pursuant to the following exceptions to the Open Meetings Act, 5 ILCS 120-2C, 1, 2, 11, 12, and 17. Do I have a motion?
Motion. Second.
Thank you. The motion has been made and seconded. Madam Secretary, please take a roll call vote on this motion.
Roll call vote on the motion to go into closed session. Aye or nay, Director Bott? It is absent.
They're all turned off.
Director Curry?
Aye.
Vice Chair Deere is absent. Director Garza?
Aye.
Director Harrington?
Aye.
Director Ryder?
Aye.
Director Robinson?
Aye.
Director Sorrell is absent. Director Webster Cross? Aye. And Chair Taylor?
Aye.
You have 8 yeas and 3 absent.
Thank you. The ayes have it. The motion carries. Thank you. We're now going to close session. Thank you all for joining me.